During this session, I'll be discussing pediatric optic nerve disorders. It's a group of disorders that can cause decreased vision, nystagmus, and associated with a number of different systemic diseases. There are three specific objectives for this session. By the end, you should be able to recognize 5 developmental anomalies of the optic nerve and list their systemic associations, describe the presentation of optic neuritis in children, and list 4 causes of optic nerve elevation in the pediatric population. Consider the following question, which is not paired correctly: optic nerve hypoplasia and endocrine dysfunction, morning glory disc and schizencephaly, optic nerve coloboma and cardiac defects, or optic nerve pit and retinal detachment. Feel free to pause and consider this before you move on. Optic nerve hypoplasia is fairly common in the pediatric population. It's important to be able to recognize this. Patients may often have nystagmus and decreased vision. On examination, the patients will have a small optic nerve and may demonstrate what's called a double ring sign, where you can see the scleral canal outside of the actual optic nerve. It can be unilateral, bilateral, or asymmetric, and may be from either primary deficiency of retinal ganglion cells or may be a result of retrograde loss of axons from CNS processes. Vision may be normal to no light perception dependent upon the extent of the hypoplasia. Optic nerve hypoplasia can be associated with a number of intracranial abnormalities. Most commonly with pituitary dysfunction, these patients may have ectopia of the posterior pituitary and imaging, but even patients with normal imaging may have endocrine dysfunction. So there should be endocrine evaluation, or at least consideration by the pediatric team for all patients with optic nerve hypoplasia. They may have other developmental issues from cerebral anomalies such as schizencephaly, migration defects of the cortex, or cortical heterotopia. An MRI can be considered for all patients as well. This is a clinical photograph copied from the BCSE series of a patient with optic nerve hypoplasia. It may have lost some resolution in the copying. The optic nerve is small in this photograph with a double ring sign, which is a scleral canal outside the area of actual optic nerve tissue. When I'm judging patients with optic nerve hypoplasia, I'll record the size of the optic nerve in relationship to retinal veins. So a small optic nerve may have a diameter of maybe 2 retinal vein thicknesses, whereas a more normal sized optic nerve may be 5 or 6 retinal veins in diameter. This is a sagittal image of a patient with posterior pituitary ectopia. Image A shows the black arrow pointing to the area of the normally placed anterior pituitary, and then photograph B has the area of the posterior pituitary very bright just above the area of the white arrow. This comparison of the right and left eyes shows more clearly what the double ring sign looks like. Photograph A is a normal appearing optic nerve. Photograph B shows optic nerve hypoplasia with very small amount of optic nerve tissue just nasal to the bifurcation of the vessels. The remaining size of the scleral canal is normal, and it's this white area that's comparable in size to the entire optic nerve in the normal right eye. The second developmental anomaly optic nerve we'll be discussing is morning glory disc. This is a very recognizable process of the optic nerve with a funnel-shaped nerve head. It typically has a central white glial tuft with numerous radially oriented vessels and a pigmented raised annulus outside of the area of the defect. Usually you've got very poor vision, and it's usually unilateral, and it can be associated with retinal detachment as well as basal encephalocele. This clinical photograph of the optic nerve shows a typical morning glory disc. There's a central glial tuft. The optic nerve is excavated with a funnel-like appearance heading posteriorly behind this tuft, and the vessels are oriented very much radially or spoke-like coming out of the optic nerve. There's an area of peripapillary atrophy with a pigmented annulus as well. This CT of the brain orbit shows a defect with a basal encephalocele extending down into the nasal cavity. Patients with morning glory discs are at risk of this, and you should be careful during probings or having your colleagues be aware of this when performing nasal surgery. The third congenital anomaly we'll be looking at is optic nerve coloboma. This is usually an infranasal excavation of the optic nerve head and may be associated with retinal, choroidal, and iris coloboma. Vision is variable depending upon the extent and location of the coloboma. It's associated with the charge syndrome with heart defects. And optic nerve pit may be a variant of optic nerve coloboma. Optic nerve pits can have non-rhegmatogenous retinal attachments thought to be a communication with the sub-arachnoid space. So here's a typical appearance of an isolated optic nerve coloboma. You can see nerve tissue superiorly and nasally with a large excavation infratemporally in this patient. Here are a number of photographs of other manifestations of coloboma. The top left picture shows an iris coloboma, which is typically infranasal. Patient in the top right picture has a large inferior retinal choroidal coloboma. And then the bottom left picture shows a large coloboma incorporating both the optic nerve and the inferior retina. This patient has a small optic nerve pit temporally in the optic nerve with an area of subretinal fluid extending toward the macula. The fourth congenital condition of the optic nerve is peripapillary staphyloma. This is less common than the other diseases we've discussed so far, but involves a posterior bulge in the entire sclera surrounding the optic nerve. So the nerve sits at the bottom of the depression, and the vision may be affected by stretched retinal elements. So as opposed to an optic nerve coloboma where the pit is in the center of the optic nerve, and staphyloma, the optic nerve is in the center of the pit. So this is a clinical photograph of a patient that has a posterior staphyloma, which is a focal ectasia posteriorly that involves the optic nerve. These have been associated with contractile elements, which is thought to either be due to smooth tissue in the orbit or to fluctuations in the pressure of the orbit and CSF. Myelinated nerve fibers are a fairly common incidental finding on ocular examination. The axons usually are myelinated from the lamina curbosa posteriorly to the lateral geniculate nucleus, but occasionally myelin can extend anterior to the nerve head. Usually it's inconsequential unless it extends into the macula, and I've seen a number of patients with this unilaterally with extensive myelination of the nerve fibers. They develop a large amount of anisomyopia in this eye. So here's a patient with extensive myelination extending from the optic nerve head. The edges tend to be feathery looking, and the myelination can obscure the vessels. Okay, we've discussed the congenital anomalies of the optic nerve. Now we're going to cover 4 acquired disorders of the optic nerve. They're optic neuritis, papilledema, optic atrophy, and optic nerve glioma. Before discussing optic neuritis, I'd like you to consider the following question. Which is true regarding optic neuritis in children? A. Most cases occur after viral infection or immunization. B. The majority of children will be left with vision loss of 20/50 or worse. C. Optic neuritis in children should never be treated with steroids. And D. Most patients that have pediatric optic neuritis will go on to develop multiple sclerosis. Okay, most cases of optic neuritis in children are after a viral infection or after immunizations. It's thought to be an autoimmune process, but possibly is a demyelinating process. Usually there's good visual recovery, but if the visual recovery is significant, they may require IV steroids. And the link to future multiple sclerosis development is less clear in children than it is in adults. This patient has a typical macular star of neuroretinitis, which may be seen in some children with optic neuritis, although it's most often just a elevated optic nerve, sometimes with hemorrhages. Papilledema in children is an elevation of the optic nerve head with edema and a presence of increased intracranial pressure. It can be from either intracranial mass, hydrocephalus, or pseudotumor cerebri, and it demands imaging, and if that's normal, a lumbar puncture. The papilledema findings are very similar in children as they are in adults. There's nerve head elevation with thickening of the nerve fiber layer. You get loss of previous cupping as well as loss of spontaneous venous pulsations. You'll get obscuration of the retinal vessels. There can be peripapillary hemorrhage and nerve fiber layer infarcts, and there may be retinal folds in severe cases as well. The clinical findings of pseudotumor cerebri are similar in children and adults, although children with pseudotumor cerebri are much less likely to be obese as their adult counterparts. There's papilledema with increased intracranial pressure. The ventricles appear normal in imaging or slightly thinner, and there's no intracranial masses. They can present with headaches and transient visual obscurations, and treatment is with Diamox or Lasix. If the headaches persist or if there's visual field progression, there can be consideration to LP shunting or optic nerve sheath decompression. Here's a patient that has very prominent elevation of the optic nerve with loss of the vessels as they cross the border and vessel tortuosity as well. While it's important to be able to recognize papilledema in children, it's also important to be able to recognize pseudopapilledema. So before we move on, here's a question to test your knowledge. Which of the following is not a cause of pseudopapilledema? A. Optic nerve drusen. B. Hyperopia. C. Familial exudative vitreoretinopathy. Or D. Leukemia. So 4 causes of pseudopapilledema include optic nerve head drusen, which is very common, infiltrative processes or inflammation of the optic nerve, hyperopia, or what we call an anomalous disc. So here's a patient with typical, what we call lumpy, bumpy appearance to the optic nerve with some glistenings of optic nerve drusen exposed. You'll see all the vessels are very clearly distinct on the surface of the optic nerve. In those elevations, the nerve fiber layer appears normal. Confirmation of optic nerve drusen can be done with B-scan ultrasonography showing a echo-dense area, and how this can be done is by turning the gain down on the B-scan and seeing this area persist even with very low gain. The material of optic nerve drusen is thought to be a hyaline-like material seen here that's somewhat lost due to fixation changes. Evaluation of the elevated optic nerve should also consider infiltrative processes. Here, a patient with leukemia shows elevation of both optic nerves. When evaluating a patient with optic atrophy, it's important to remember that optic atrophy is a physical finding, not in and of itself a diagnosis. It's a result of loss of axons and supporting microvasculature, and it results in a bland appearing yellow to white nerve head with loss of the surface capillaries. There are a number of different causes of optic atrophy that's important to consider when you're seeing a patient with an atrophic nerve. There is a hereditary form of optic atrophy that can be seen running through families. Leber's hereditary optic neuropathy can also cause optic atrophy. Burned out papilledema can result in atrophic appearing nerve. Retinal degenerations, optic nerve compression, and trauma can all lead to optic atrophy.